At this panel section, like Chief Hayo Silu said, I'll be dissecting the presentation and aiming towards looking at what are we taking away. So my panelists this morning will be Dr. Muyaina, the EDCO NPHCDA. Can we appreciate them as they come up the podium? He's a big brother, a senior colleague, and a veteran in the area of development as well. And then I also have Dr. Babagana Kundi Machina, all the way from Yobe, who is the Executive Secretary of Primary Healthcare Board. Let's appreciate them. We have somebody that just moved to the seventh floor. But we are not taking him to the seventh floor this time around. We're just bringing him to the podium. So the pleasure is mine to welcome Dr. Mohammed Leki, who's the chair, Sector Reform Coalition. And the powerful woman in the house, Dr. Ekwedeme, apologies the way I actually massacred the name. Dr. Ekwedeme Udom, who is the chair, national advocate. She asked me not to mention this, but she was a deputy controller, former deputy controller of prison. Yeah. So now correctional services. You have welcome on the podium. Thank you very much, sir. And we have a very, very good friend, a young lady that is doing very well in the area of health financing, Joy Wisu Zuho, Joy as financing specialist. Joy, please join us. Because the ED has to leave very soon, we start with him. And okay, you're welcome. Let's the panelists sit very well. You're welcome. Okay, great. So Dr. Muyaina, during the course of your presentation, let me start by congratulating you for articulating a very clear strategic direction. But during the course of presentation, you acknowledge the fact that we've been very, very suboptimal in terms of harnessing the resources in the room, in terms of from partners, from civil society, from private sector, and government as well. I would like to find out from you, what do you want to do differently, or what do you like to see? Because it's not only you now. What do you want us to do differently in terms of working better to optimize resources? Dr. Mui, over to you, sir.
Thank you very much for that question, Dr. Lawadi. I think I'm very fortunate, or we all are very fortunate, but I'm particularly fortunate I have a boss who gets it, who understands the issues and wants to do something about it. So he's already put in place a framework to address just that. So when we talk about the SWAP, what the SWAP is an approach to execution that gives you an end-to-end view. So it's called a sector-wide approach. And at the top of it, that's really what informs, and I'll break it down to what that really means. At the top of it, that is what is helping us to address this very quickly, which means all of us are part of one sector, and we identify our set of priorities, and we're all working towards the priorities. There are many problems. It used to be that everybody will come define their own problem, and my own problem is that, people don't have good toenail care. And you just be doing that on your own. Somebody else is interested in antenatal care 1. Somebody else is interested in antenatal care 2. It's not that bad, but that's just an example. So what the sector-wide approach is doing is the following, is that with the government at the center, again, led by the coordinating minister for health, is really articulating what are a set of priorities that we are all aligned to. So when we say we want to achieve universal health coverage, what does that mean? That means in Nigeria, we want to save lives, we want to reduce physical and financial pain, and we want to do that for all Nigerians. So if you want to save lives for all Nigerians, what does that mean? You identify what are the things that are killing people the most and address those. There are 5,000 different things you could do to save lives, but it's not all 5,000 that are killing most Nigerians. It's 3 or 4 things. So what are the causes of maternal deaths? What are the causes of child deaths? Can we all organize ourselves around that? That's the first thing. The second thing is coordination of our financing and resourcing. Our people our capabilities, but also our funding to say, okay, if you're going to achieve this set of objectives, these are the pathways that you need to invest in. For you, federal government, which one are you doing, both in terms of human resources, in terms of infrastructure, in terms of commodities, in terms of the other systems that allow that? For you, who's bringing, what are you contributing to that? For you, what are you contributing to that? So that it minimizes overlap. The third thing is we're having one conversation to review. The Lucia, I believe is her name, mentioned how are we measuring. So we're having one conversation. And I also referred to it that we're right now actually in the middle of submitting to the president our performance report on a quarterly basis. If we don't do well, we get fired. That's how the president is working. That's how the coordinating minister is working. So that's why also even I prioritize where I spend my time. If you are not contributing to the agenda, you don't get too much attention from me. Nothing against you. We're still friends, but you have to be very focused on the outcome. So that one conversation, that includes the federal government, the state governments, the LGAs now, but also all of our partners and donors, in one room to say, these are the targets that we set. How are we trending? Where can we do more? Where are we getting off track? What are we learning? And how do we put that out there? I think those are some of the parameters. And you can see that at the national level. But for those of you who work with the National Primary Healthcare Development Agency, you also see that at play every day in the way we're trying to do things. I hope you see it, but that's definitely what we are trying to do every day in the way we're working. Thank you.
So thank you very much, Edie. I think that was very, very clear. If I heard you clearly, I think we need to achieve harmony and alignment around three important areas. One, in the area of a priority. We have to have alignment and harmony there. The area of how we invest our resources and in the area of how we monitor and do the accountability. I think that is pretty clear in terms of the new paradigm shifts that we are looking at. Let me go to the subnational level. Dr. Babagana, you are the Secretary General of the Forum of State Primary Care Board CEOs. Nigeria is a federation. We have the national, we have 36 states and FCT. Whatever the policy direction the minister, the honorable minister, the coordinating minister, the ED, they are setting, if you are not in alignment, it's not likely to work. How do you want to deploy the energy and power resources of your forum to support this policy direction, Dr. Babagana?
Thank you so much. I think, as has been said by the ED, we have one conversation. All our governors, all of us as the CEOs of the state primary care boards and agencies are appointees of our various governors. And all our governors are part of, have in fact signed the compact with Mr. President and all the development partners in present, at the villa sometimes last year. And we are to share and operationalize the vision of our principals, the governors. And the governors represented by the Governors Forum, they are signed that compact. There has been also another signing by our immediate bosses, the Honorable Commissioners of Health, during the zonal roadshows for the swap, where every Honorable Commissioner for Health also signed up on behalf of the health team of the state. We are all committed to ensuring that we align with this noble vision of the Honorable Coordinating Minister and ensuring that we also mobilize state or subnational level resources to actually key into this one plan, one prioritization, and of course, one accountability framework. For instance, there are states, or I can say for my own state, for example, in Yobe, we have already started that conversation, especially in the light of the local government autonomy that has been said. And we are very pleased that already our NPHCDA, Dr. Muyi, I know, is already looking at how to strategically take advantage of the new development and see how the PSC space can actually be ring-fenced and further even strengthened, leveraging on the LGA autonomy. At our own state, for example, we have engaged all the, recently there was an election last month, new chairmen were elected and inaugurated, and we leveraged on that and engaged all of them on a 5-day retreat, a residential retreat, told them about the direction, including swap, and where we think they fit in, and what responsibilities they have. And we have to look at a way where there's mutual responsibility. There's responsibility that the federal government will take. There's a responsibility that state will take, and the LGS, that will ensure that all of us are looking at the same thing. We budget the same way. We have the same conversation and ensure that we all play our parts. So the LGS will now not think that with the LG autonomy, we are looking at maybe undoing PSC under our roof, but rather using their own autonomy and given the responsibility to actually also cater for the health needs of their people, they see how they can align with the national and the state level to further strengthen rather than weaken the PSC under our roof. So we are working towards engaging more stakeholders at the subnational level and also in terms of mobilizing resources and providing stewardship, including the issues around mutual accountability. The Honorable Coordinating Minister has just started the ministerial review. And as I have said earlier in my goodwill message, some of us at the state level have already also started doing that, holding our subordinates, especially the LGAPC directors and various program officers responsible for results. So I think these are things that we can do at the subnational level to support this novel initiative of the Honorable Coordinating Minister and the Executive Director to see that we strengthen PSC going forward. Thank you.
Okay, thank you very much, Dr. Babagana. You mentioned a number of instruments that you are going to deploy to ensure there's alignment with the national policy direction. One of them is compact. I'm happy that you are scrutinizing this at the subnational level. I think this is a very important instrument for the non-state actors to look at how do we use it to ensure alignment. You mentioned the issue of LG autonomy. Let me go to Dr. Lekki. Dr. Lekki has been, just yesterday, they had a very important meeting with the Association of Local Government Chairman on this issue of local government autonomy, which some of us sees as a double-edged sword, depending on how it is managed. And so what is the conversation like? You've had the position of the ED in terms of, he said in his own words, we have to protect the sanctity of peace on that one rule. Is the conversation in that direction, Dr. Lekki?
Thank you very much. Our meeting with the Algon yesterday, we thought was historical, and for many reasons, because they have just gotten a very important, Supreme Court endorsement, which gives them some form of financial autonomy, which the states don't like. Even some of the Algons from our discussion yesterday, we couldn't tell, but it looks like they are welcoming it, but they're not particularly strong enough to know how to take it forward. And so one of the things we agreed with Algom yesterday was to create a committee that will work on this, particularly how does this dovetail into ensuring that they play their constitutional role in terms of PHC. Because PHC have been largely, done, supported and funded by partners, where it works, and the federal government through NPHCDA, and to very degree by the state, and to no degree, one can say, by the local government. So there are issues there that we need to work, but it's an important development, and the roadmap on how to engage with this new development, which we as Executive Reform Coalition think is a good development, is just emerging. I think an important side of that is, I'm glad that the DG of NPHCDA, our friend Muiwa, is here, is that there needs to be an intentional engagement between NPHCDA and Executive Reform Coalition to actually sit down a round table discussion on how to look and dissect all these things and come out with what is more suitable that will be helpful in I think this go both way for PhD under one roof. This is
Dr. Lakey, I get your point clearly. Probably we need some to do some policy analysis, including understanding the political economy of
If we don't go to the field, we are not going to get anything done. Now, but the owners of the land were only planting cassava. And lo and behold, somebody came and planted coconut. And they didn't make them understand the value of coconut. Do you know that coconut, a barrel of coconut, is more than the price of a barrel of coconut is more than the price of a barrel of oil? You can check it out. But these people burnt the entire plantation. They burnt it down. Because they planted coconut in their land, that they've been planting cassava. Do you understand ownership? Nobody explained to them that this coconut will be more useful, and that is because there is going to be this refinery here in your area, because coconut actually does grow wild there. So you took their cassava farms, and they had actually prepared these farms for cassava. When the then commissioner had a brainwave, I prepared it for cassava. I can take the money and plant, rather, instead of preparing it again, I plant. Do you understand? So please, we've got to start thinking without ownership. Do you know those people now want the plantation to come back? Because now people have explained to them that look at what has happened. I'm using this because it's really helped from everything. That you can use to do. I'm thinking when I was at London tropical, we didn't do came back to Syria. He told me take those and Grand Prix now refused. So I'm going to studying it in the school of medicine. Should I buy?
You want to make these women have safe delivery. We know that many of them come for antenatal, but they prefer to stay at home and make use of traditional birth attendant. Thank you.
Thank you. That's noted. The second, young man over there. Okay, thank you.
Thank you very much. And my question is to the ED. My name is Victor Daniel. The SWAP approach is very laudable, but one very important component is knowledge management. There's a lot of intervention and implementation by a number of partners, CSOs, and all that across the country. One thing we see clearly is that many of what was being done in terms of replication of funding, there's also the fact that a lot of what we want to see and what we want to learn is being done by someone or has been done somewhere. But if you look at the way the system is run now, you cannot have any access to this knowledge or this information or this lesson. So my question is, how is the ED thinking about bringing together these lessons, these interventions that are being done, and use that to forge the way forward?
Thank you very much, Dr. Highworth, then the young lady in pink. Everybody's a young lady. It's okay.
Thank you so much for yielding the floor. I'm the General Secretary, she's RC Nigeria. I want to sound a note of caution for the states. It is very easy to adapt the national protocols, the guidelines, policies, but it is important that all the 36 states and FCT should look at the establishment legislation for the private care, but particularly the funding mechanism. Because at the end of the day, when you have the health authorities in the LGS, the chairman and the secretaries are already known, but the directors of the various departments are members, particularly the treasurer, the local government. When the approval is given for this thing, if the financial arrangement in your legislation is not in tandem with that, they will not pay. So please let the states look at that and update your financial arrangement to reflect all these that you are bringing from the national. Thank you.
Thank you. Please just look backward and give the microphone to the lady. Thank you.
Good afternoon, panelists and everyone. My name is Fola Shadi Akpan. I report for the News Agency of Nigeria. I understand that UHC has there's a target, there's a 2030 target of achieving universal health coverage the world over. So my question is this: are we on track towards achieving this goal? That's one. Then what's the role of the private sector in helping us to, even if we are not on track or we may not be able to achieve by 2030, what's the role of the private sector in helping us to at least get close, to this goal? And then political will. I think the NPHCDA executive director may be able to answer some those who are not in government or who knows answers to this goal to help us with that. Thank you very much. That's my question.
Thank you. We'll take two more so that I don't lose track of the question. One, okay, USAID here, so that will give floor to the donors as well. And FCD, Chidera, the young man to you.
Okay, mine is directed to the ED. I was very happy to hear that we now have a dashboard that will help us monitor, track PHC functionality. But we also have a challenge which has to do with the identity of health facilities in country. We have the nomenclature fragmented. So what are we doing to ensure that we have a common identity for health facilities across the various data sources we have in Nigeria?
Okay, so thank you. Good afternoon, everyone. So my name is Samuel Ali from eHealth Africa. I think it was Dr. Ufoma that said anything for the people should be planned by the people. It should be done by the people. It should be owned by the people. My question is directly to the ED. We've heard about the PHC, is it under one roof or under 7 roofs now? Under one roof, yes. And then the swap strategy, which are fantastic, wonderful ideas. But the question is, are these policies community driven? What were the involvement of the communities in terms of, driving this policy? We talk about UHC, which is, more of a community-focused, framework and strategy. So what are we doing, to get the communities more involved in driving these policies? Or we just sit somewhere and then we craft something really, really nice and then we'll put it out there, but without community involvement. Thank you.
Thank you. Last one from Chidera here. Please be fast.
Thank you very much. My name is Chidera Chukwu. I'm a proud Muiz boy. I worked with this ED in 2 organizations. I'm a staff of the FCDO. I serve as a health advisor. Now to my question. Given the implications of the LGA financial autonomy, what, ED, do you think are the key obstacles that NPHCDA might face in achieving its mandate? And how can the civil society best support the agency in navigating these challenges? Thank you.
So thank you very much. I think we'll pause here now. We'll hand over to the ED to actually, ED with, excuse please, do you have any question from the online participant? It's very easy to marginalize the online paper, right? Do you want to read it out quickly or something? Can somebody help me with the microphone, please? Thank you very much. Yes.
Almost 8 months ago. It's nice to know what has happened differently in its implementation, especially at the subnational level. What's done differently now?
I think you are using a pseudo microphone. And if possible, you can mention the name of the person asking the question.
Thank you. This is from Ifeanyi May. The swap was launched last year, almost 8 months ago. It would be nice to know what has happened differently. It's in inverted comma in its implementation, especially at the subnational level. What's done differently? Now, are there major challenges? 2, are there workable feedback mechanism to NPHCDA? This is from Omori of Yahweh. Are there workable feedback mechanism to NPHCDA in ensuring stated resources are used for the purposes they are intended for? From Ahmed, I recommend that for us participating on-site and virtually to directly support the UHC initiative to adopt a facility, I guess from Pishan, close to our communities through utilization of its services, provide direct supervision, promoting community participation. This way we can understand whether the new approaches developed by NPHCDA and the FMOH are working, and where there are challenges, we can take it up with the right authority. This should be only first priority as individuals while supporting the collective efforts through various organizations. From Yemi.
I think that should be the last one, so do it quickly.
Beautiful presentation, a good effort at improving MSH. How are we leveraging this momentum to address other disease burden, especially preventive measures? Secondly, what is the plan to strengthen the referral system among healthcare institutions to the
Thank you very much. ED, over to you, sir.
Okay, lots of questions. Fortunately, most of them actually have already been answered in the course of the conversations today. I think there are a couple of things I can deduce from the questions. I think that we should pay attention to the people online to make sure they're actually able to follow the deliberations. The questions make it clear that they're not, I haven't heard much of what has been discussed today. So I would tell, work with the moderators to try to make that happen. A role of TBAs, absolutely. For many years, I was a lone voice actually against many of my elders and teachers at the time to say that as a health system, if you really want to change the trajectory of maternal care, and we sideline the TBAs, we're being very foolish. No matter how good we are, the people are going to them. If the people are going to them, human beings make rational choices. So something know. So at the minimum, we need to learn that from them. Can they perform all services? Should they be performing any and all services? Absolutely not. But are they a critical part of the health system? I say yes. Providing services, you I should not know. I think we or ourselves, the mother responsibility to organize them, integrate them in the system. They know and provide and they refer and feed back forth into the system. We have modernized less on swap. They swap organized into technical groups. There are many earning working group that would advise and all that made little progress in your work and sort of relates to the editorial but also working with and out of position on how we move forward with PhD. So I think the key the one with from winning you into a but that conversation is on. Actually, in fact, some maybe that have gone. A part of the team to come and, then we can brainstorm and help together. Involvement of communities, similarly, I think the CSO should answer that. None of the policies was developed, as you will all be witness, without substantial input of the CSO community in the center of it. So if the voice of the CSOs do not represent the voice of the people, then you all have a problem. Not us. I think you will have to agree to that. The PHC under one roof, the National Health Act, all of the policies. The UHC Forum was part of it. The Health Fund was part of it. Everybody, CSOs as a group, were part of it. And the reason we have this engagement, the reason I am here is because we are working under the assumption that you are a voice of the communities. So I'm hoping that that continues to be true, going forward. Are we able, as National Primary Healthcare Development Agency, to go to every community and do focus group discussions? No, and that's in fact unnecessary. But we work with the states, but we're government. Government can only do so much. There's government on one side, there's civil society on the one side when you are trying to get input from the community. So I think to what I said earlier, I think we all need to step up to our responsibilities. If there's anything going on in the health sector and the voice of the people isn't in there, then I challenge you all to try to figure out a way to help us do better with that. Implications of the LGA autonomy, again, like I said, a lot of thinking is going into that. But the way where we are landing is that it's in fact a big opportunity for us. What happened is, if you recollect, for those who know, prior to 2011, we were in a very fragmented, I think in the 1990s, up until the 1990s, we had a pretty solid PHC system that was quite centralized, and the federal government says this is what you do, everybody does it, you know? And then between then and about 2011, everything, you know, we had democracy and everything kind of broke down a little bit. The responsibility was split between states and LGAs, but in a very unclear way. And some did great, some didn't do so great, some did nothing. There was just chaos. And then in 2011, May of 2011, I believe, at the National Council on Health, the NCH adopted the PHC under one roof as a policy, following a lot of consultation and work at many different levels, but definitely with a lot of input from people sitting here today, who I believe represent today and represented at the time the voice of the CSOs. And the idea was that, you know, to coordinate at the sub-national level, at the state level, you want to have a fund for PHC. And that fund, rightfully so, will be co-financed by federal, state, and local government authorities. Fortunately, in 2014, after so many years of work by exactly the same set of stakeholders, again, the National Health Act. And what the National Health Act did, in fact, was to establish a national health system, to say that there's not a federal health system, a state health system, or a local government health system. There's a national health system. And at the core of that is the Basic Healthcare Provision Fund as a financing mechanism for primary healthcare services or basic healthcare services. So federal government money, state government money, LGA money go into this one. And partner money, by the way, go into this fund. And that's the law of the land, by the way. So in fact, nothing now is new. This is not an innovation. This is really just an attempt for us to say, okay, now let's follow the laws of the land and try to do it properly. And over the years, of course, the PHC under one roof implementation has varied quite widely. States like Yobe, like a few other states, you know, Yobe is here, so I can call him. I've done an excellent job, actually, of really implementing, you know, PHC under one roof. Some other states have struggled, you know. So what we're trying to do now is, how do you standardize? What does it mean? The scorecard that was developed several years ago, is that still relevant, or is it due for an upgrade to try to reflect what matters for the day? You know, those kinds of conversations you need to be a part of. Workable feedback mechanisms, we're working on all of that. I think one of the things that we're also trying to do is have a user-facing interface, even on the web, where you can provide feedback. Right now, we already have whistleblower lines and stuff for more problematic things. You go in the field, you find one state chopping money or one or that, and we get a lot of that, and we act on that. And that's a core part of our partnership with law enforcement and the anti-corruption agencies. It's not my job to pursue corruption or to figure it out, but when I get the report, I tell the people who are mandated by law to do it, and they act on it. I focus on building out primary healthcare services. So, but we need that information. You give it to us, give it to the anti-corruption agencies if you see things. But more constructively is that when things are working, also let us know. And where there are things that we can improve, you know, we want constructive feedback to say it's not only that somebody is stealing or somebody is being malicious, but you know, this is not working well, this has broken down. Can you talk to the states, but also talk to us? You know, we have access to the states, and we are working to expand the channels of access. Again, I've had conversations with Budget, I've had conversations with Tracker, I've had conversations with NY, different CSOs to say, come, how can you help us to be more transparent, to be more accessible? There's only so much I can do from my office. That's the point. You get what I'm saying? There's only so much that I can just do from my office, but we have all of you with different platforms, with different mechanisms. Come and tell us, this is what I am contributing to this. Don't come and just ask me the questions. Tell us some of the answers and some of the solutions. We don't always have the answers. I think that's really, those are the questions. Somebody asked about what is happening in SWAP. I think we already talked about that. What subnational level, what's changed that we allow my colleague from the subnational level to speak a bit to that. Hopefully I have touched on most of the questions that were asked.
Thank you very much.
Apologize that I really do
Let's
need to leave.
appreciate it.
Thank you.
Dr. Bakana, you want to answer some of those questions? There's one push to you. So thank you very much, Edie. That's Edie, sir, before you go, I'm very sure Nigerian UAC Forum and Health Sector Reform Coalition want to be part of that conversation around LG autonomy that you've already started. We want to be part of it. Thank you. So group photo, sorry, missing protocol. Okay, group photo. Okay. Should we come down? Edie, okay. Madam Lucia, she come. She's our guest. Yeah, so the session is not yet over. Okay, thank you very much. So apologies, Joy. Thank you very much for that patience. So the question for Joy is that there's a very, very great presentation from Lucia about the accountability mechanism. SLAM is well celebrated as a success in Nigeria as well. Lucia, SLAM is celebrated as a great accountability success. The next question is that times are changing. The policy environment is changing. We have SWAP and there's technology and everything. What is the next frontier for accountability in the health sector? Building on what we have already done, what are the other things we should be doing, building on the success we've achieved so far? Over to you, Joy.
Thank you, Dr. Gaffer. So I think the word accountability is fast becoming a buzzword, even in the health sector. Like, people talk about it a lot, but the question is, what is the understanding of that word accountability, and what does it mean at the different levels? Because what it means at the national might be different to what it means at the state level and to the layman and the community level. And sometimes people see it as scrutiny or trying to question what they are doing. And so come off, like, once you talk about accountability, antennas go up and people are wondering, what are you trying to look at? Why are you asking up for the records or for the data? But really, accountability has to be understood to be about taking responsibility. And I think the executive director has highlighted that a lot, that accountability is the responsibility of everyone. So I think in the recent times now, with the new policies, because we've had the BACPF accountability framework, we've had the different policies, National Health Act, and so many others. And a few accountability structures were put in place. But why have we not optimized the results that we wanted to get from those? So I think awareness is the starting point. And he made a good point that at the national level, we are all seated here. We are aware of the priorities of the NPHCDA. We understand the SWAP, at least to a great extent. But I did an assessment recently, and I was speaking with someone at the state's health insurance scheme. And to be honest with you, he is not the executive secretary, but a director, and he couldn't really explain some of these national policies. So again, that shows that if at that level, awareness is still limited, what then happens at the LG and at the community level? So it's first to have a shared understanding of what we need to be accountable for. What are the indicators that we are tracking? And what is the responsibility at the different levels? So I think starting from there. And then for the SWAP, I know a lot of committees are existing. We have the M&E working group, the one focusing on funding. But how inclusive are those technical working groups? Do we have the minority included in that? Are the community voices included, like we have all been saying? And again, it is our responsibility to take those feedback back to the Secretariat to ensure that we are really, really, getting to the grassroots and making sure that their voices are heard. Also, data, we can't talk about accountability without data. So strengthening our data system. I was at a validation meeting on the state of primary healthcare delivery that One Campaign and Corona Management Systems did. And they realized that a lot of the facilities that they assessed had no capacity, even if we are rolling out digitization right now. Yes, digitization is one of our health sector priorities, or is one of the key ways of achieving the results. But how ready are the facilities when they don't even have a computer, they don't have laptops and things like that? So I think it starts from there. So when we talk about accountability, putting in place these systems and moving away a bit from just funding to performance-based funding. Of course, I won't talk about anything accountability without thinking of the results. What are we funding? What is the results we are getting from that? So I think those are some of the considerations that we need to be thinking about now. Thank you.
So thank you very much, Joy. That is a very important, a number of salient points there. I think we have to be on the same page in terms of when we say accountability, what exactly do we mean? Because accountability means different things to different people. And, borrowing from your words, we have to be very clear. It's about transparency, knowing, having information about different things, about the input, about the process, about the outcome, about the impact, and everything. And I get your point about having necessary infrastructure in place to be able to promote accountability. We have to digitize things. The world has moved beyond processes is digitization, which is very important. Somebody share experience of a tertiary hospital where they digitize their financial management process. And guess what? Few weeks after, the accountant resigned because the work wasn't very lucrative again. So I think it is very, very important for us to do that. Thank you very much, Joy. Before I go back to the audience, one house, please, one house. Before I go back to the audience, Dr. Lekki, I have a question for you, especially looking at the financing landscape for primary health care, especially in the context of our donor transition. From the available information, by 2028, probably will graduate from Gavi support. Even when we're still receiving Gavi support, we have a lot of unfinished businesses. Nigeria is still one of the highest number of zero-dose children. So what is the civil society, sector reform coalition and others actually doing to ensure that we're able to safeguard resources for primary health care, especially in the context of donor transition? Over to you, Dr. Lekki.
Everybody knows that civil society's strength lies in advocacy and accountability. So we can go and advocate, and we'll be very successful in this. If not for the advocacy and the step taken by CSO, we will not have the National Health Act today, and we will not have the Basic Healthcare Provision Fund, which is driving primary healthcare across the country. So that in itself is evidence of what we can do as CSO. Now, I have been saying, as I get opportunities to say, that there is room. We also hear about this innovative finance. I've been banding around a lot several years now, without any concrete step being taken to translate this so-called innovative finance into reality of new streams of revenue for PHC. There are clear new streams of revenue that can come for PHC. Instead of us going after them, we throw open the difficulties, the challenges, why that cannot work. How that is the law. An example is the sin taxes. And I think we need to take a resolution in this house. Those sin taxes, those taxes are currently being collected by government as either as excise duties or otherwise. And it's huge sums of money. And their collection is rationalized on the basis of the fact that they are sin taxes, alcohol and tobacco. They are injurious to health. So why don't we now do the flip side of the argument and invest this injurious money we are collecting right now in huge amount of money and spend it on health? It makes so much sense. But the money is just being collected, nobody knows where it's going to. The moment each time I've raised this issue, we are told that the Ministry of Finance will not allow it. It's true, Ministry of Finance is like, I had a brother when I was in the US, I sent him money to keep for his account. When I came back, asked for the money, was asking me, what do I want to do with the money? This was my money I asked you to. He's asking me, what are you going to do with the money? Ministry of Finance does not like to release money. You can see the difficulty we're having in the releases of money, even if it's budgeted, appropriated, signed into law by the president. Releases are an issue. So that should tell you. So you need to fight for the release. We fought for the Basic Health Care Fund in the National Health Act. Our sister, Dr. Minister Ngozi Iweala, wrote to the president not to sign that into law. Who would have believed that? Such a very, World Bank-driven person was against and wrote. We took her letter and replied clause by clause why the law must be signed. The law was signed. That's how you fight for what is right. So we need to, we have this now as an opportunity. Those sin taxes, somebody gave a presentation, I think it was in this room, and they quantify how much it is that we're currently collecting. If we can go for all of it or part of it, we'll have enough money to supplement the Basic Healthcare Provision Fund to fund this primary health care. So we need to all mobilize and go for what we may call a legislative instrument to drive the need for those sin taxes and even part of VAT too to be earmarked for health, permanent health care. We can do it. It's not going to be easy, but we've done it before. So we'll just dust up our strategies and go on the street and go there, do the analysis, do the presentation, convocate, have roundtable discussion, and march to National Assembly for them to pass it. It will be passed if we're serious. I think we can do this within 1 year. Thank you.
Thank you very much, Dr. Lekki. I think the organization that did that great assessment, LHSS is in the room alongside the DJI Consult to work together. They have a very, very good evidence about how much are we going to generate to the extent that what problem are we going to encounter and how do we overcome them. I think what we need now, we need more determination, and I'm happy we have people like Dr. Lekki in the room. I think we need a sort of a standing committee or something that will continue to work on it beyond the lifestyle on any particular project. I think it should be one of the most important takeaway from this conversation. So thank you very much. On this note, we would like to take a last round of contribution questions and ask our panelists to answer if there is any. I'm very sure beyond the DG, you have questions for other panelists as well. Do we have questions or contributions? Or the sugar level is too low for us to be able to raise up our hands, right? Oh, okay, one hand is up. Which other one? Okay, let's take that question. Maybe in the process, or that we boot and ask their question, right? And then let's take. It's very easy to marginalize the online people, right? Exactly. So let's take note of other contributions from the online audience. Go ahead with your question, please.
Okay. Good afternoon. My name is Paul Isiugo, health coverage. How do we get the private sector to be more involved? Whether in terms of funding, whether in terms of capacities that they already have, they can bring on board. We are talking about private sector already have these capacities. They have the facilities, they can support this process. How do we better engage with them to ensure that this come to fruition? Thank you.
Okay, good question. Private sector participation. Somebody helping us to harness questions from the online participants? Dr. Ufoma, who else is doing that? Okay. Who is helping us with the questions from online participants? Okay, let's attempt to answer the question. Maybe it's not directed to anybody specifically, but there are a number of things that are happening in terms of the private sector engagement. I think there is a private sector health alliance that's actually spearheading, mobilizing private sector resources, and they have come up with a very, very innovative approach. They call it Adopt One Facility per LG or something, where they are able to harmonize private sector investment. Part of the problem with the private sector investment before now is that it's highly fragmented. So they are trying as much as possible, collect money, put it in the pool, redistribute it over, and use it to actually implement a well-structured project, which will be monitored and see what is happening. But of course, there are other initiatives as well. I don't know, just like you want to speak to the private sector engagement?
That's, if we want to do any engagement, we should be very intentional about it and not just talk about it as a factor when we meet like this. And once we go, nobody takes it up beyond that. So, I mean, there should be some leadership issues around private sector engagement. There should be governance issues about it. Who is taking the lead? Who is convocating the space for the discussion? So, and I think that one of the other takeaway could be the NPHCDA, if you don't already have, and I assume they will have, they should have a technical working group on private sector in the health sector. And such a group, it should be the one to come up with an agenda and then begin to identify key stakeholders in the private sector, individual personalities, businesses, and so on. That will be part of that, and then take it from there. So you need to be intentional. There needs to be some leadership, and there should be some process governance issues on how to take that forward. Thanks.
So thank you, sir. In the absence of additional questions from both in-person, okay, there's one more over there. I think we'll just take, probably that's the last one. If there's any from online, we'll take. If there is none, we'll ask the panelists to give us, share their last thoughts on this panel session. Go ahead, please.
Good afternoon. My name is Godwin Thompson Udo. I'm the CEO, Peace for Humanity Foundation. When you talk about funding on health, it is very vital. 2019 WHO Summit in Gilbert on African we see, they talk about private sector involvement in funding because there's a lot of market health challenges across sub-Saharan Africa. So what we are doing together today and what one of our leaders there has spoken is not about a group sitting together to say, okay, what are we going to do to bring this forward? We need a consultant. I remember 2002, when HIV/AIDS was much in this country. I played a vital role because I was a very young person that time. And the Ministry of Women Affairs were having much challenges with funding. So they have to bring a consultant who bring the monies from UNAIDS and World Bank. So I want us to adopt that strategy of appointing a well-renowned financial mobilizer who's going to be a consultant to harmonize the private sector, the public sector into the pool of mobilizing funds for us to tackle health. One thing all should know is that without health, no human being can strive forward, no economic development. So we are all involved. Thank you very much.
So thank you very much for that great contribution. Dr. Ufoma, any final questions from the online participant before? Because we are running off this panel section. Just take just a few, please.
I think these guys can do it better because my connection is just bad.
Who is going to do it better? Fast, please. Just take probably the three most important out of the question. The question is knowing the most important.
One, was the PH under one roof done?
What's the name of the person asking the question?
La Eze. Was the PHE under one roof done by with the non-financial independence of LGA in mind? Kazim Ayokola, What is the current status of the one PhD facility per ward? How many of them are functioning at optimal capacity? Zainab Kauru, a lot of the times we host stakeholder meeting like this and the resolution are reached. Who and who do we track implementation of the key recommendation emanating from such engagement? What is our minimum expectation in terms of deliverable for promoting PHC in Nigeria?
Okay, thank you very much. Thank you very much. That's so what we are going to do, we are going to ask our panelists to share their final thought, and if they feel like answering any of those questions, they should please go ahead. Let me start from my left. Joy, your final thought, and if you have anything to respond to some of those questions asked. All right.
Okay, thanks, Dr. Gafar. I think we should live with one thing in mind, that accountability is the responsibility of everyone here. And a clear feedback mechanism is really needed. I know Dr. Moise mentioned that something is in the works, and it can even start by a simple toll-free SMS number that if a pregnant woman or if a patient is at the facility and being dissatisfied with the healthcare provider, they can quickly send the message. And similarly, the providers as well can quickly use it to communicate any issues that they are facing, either relating to stock or any infrastructure breakdown, just for quick action. And I think what discourages people from holding on to this accountability is when they don't see the results of the efforts they have made. Like the person asked there, how are we going to track the resolutions from here? So I think at the national level as well and at the state level, we need like a dedicated, we can call it a help desk or whatever name that suits, but somebody responsible for tracking some of these efforts. If someone calls to complain, who ensures that the complaint is tackled and resolved, and how is that being fed back to the team? Thank you.
Thank you very much. Dr. Babagana.
Thank you very much. Thank you. I think my panel sort of touch on one or two of the questions that have been asked, especially around the enabling laws. The enabling laws are actually there, but they need to be reviewed, as the NPHCDA has said. Already consultations are ongoing with the state attorney generals and the attorney general of the federation. For example, in my state, there's a law just last year that was the amendment to the PSC law to actually further strengthen our financial capacity. The local governments have been mandated to actually dedicate 15% of their budgets every year to PSC. But there were a lot of, we had to do some trade-offs with the Algon that time to ensure that what we need is actually for those funds to be spent on health. They don't need necessarily to be sent to the PSC board to do that. So they can engage in some with our clearance, maybe infrastructure works and the rest from that budget. And with that, the Algon actually agreed. So it is just about, it is not necessarily who spent the money, but actually visualizing that money and ensuring that it is being spent for health. That will actually also help. So with the LGA autonomy and the LGA chairman knowing that even if they spend these monies and they attract under the swap approach, they will actually also be in agreement with the law that states that 15% of their budget should go to PSC. That will also be quite helpful for the for the private sector. There's the issue of the corporate social responsibility that we can actually look at. As you rightly said, Dr. Gafar, the issue of the initiative around adopting a PSC. Adopt one PSC is a very laudable initiative. You can say that, okay, XYZ group or a company has adopted 3 PSCs, and supporting them to be of optimal standard or adopted more or less. That can help. Then the probably private partnership. As we know, private sector are mostly for profit. So if they are not even doing it as CSR, if there are some key service delivery issues or infrastructure issues that they actually need to do, maybe build, operate, and transfer or something, or any other PPP arrangement, it can also be helpful in actually ensuring that people even have access to the health facilities. So people may have money in their pocket that are even ready to pay to access the health services, but the health facilities are not there to provide those services. Thank you very much.
Thank you very much, Dr. Bagana. Over to you, Dr. Lekison.
Thank you. I think that first and foremost, there should be some kind of communique, take away points, you know, so that that to be shared with everybody here. Taking the time to come here so that we can follow up with the implementation. But I want to use this to also make a plea. It may sound like a selfish plea. I think everybody here, whether you are working for USAID or UNICEF, should be a member of the Health Sector Reform Coalition. And the ED says something like that as CSOs or non-governmental actor, we should also be asking about our responsibilities in what is not happening or happening. We can't just come here and be eggheads that can always give, this is the best thing to do. But what are you doing about it? What can you do about it? And it's a lot we can do about it. That's why I keep going back to the issue of National Health Act. I was one of the 3 persons that drafted the National Health Act. And we mobilized people like Madam Felicia Sani, for those of you who may remember. She was a buoyant, strong woman who was the national president of Market Women Association in Nigeria. He brought all the women up who moved to National Assembly. So many such action. So you need to join various society organizations like Health Sector Reform Coalition, and we need to ensure that we have spread all over the country so that we can support this new and emerging good era. There is a POA, a plan of action, that is driving the allocation of money now to health facilities in your village. But they don't have the competency to be able to fill those forms and understand those forms. So who's going to teach them? Who's going to help them to fill those PO, to decide on their priority, cost it? It's on the basis of that health facilities now get money. So we need to follow the money. We can't be here talking English and not following the money. The way to follow the money is for us to identify ourselves that we're going to help this local government adopt a health facility and help them to make sure those forms are filled correctly and they will get the money directly. So if you do not join a CSO, like Sector Reform Coalition or UAC, you will not have the chance to do so. I appeal all of you to join. It doesn't matter whether you are working for USAID or UNICEF or WHO, you can join your capacity, and your organization can also join in its own capacity so that we can be playing our own role in mobilizing resources, in helping the people who are the right holders to access these resources and have facilities change for good. So that's something I think we need to do, going forward. Thank you.
Thank you very much. That is well noted. Dr. Udom.
Thank you. Mine is just that let's not let this opportunity slide off our hands. We have to act. And that, like Dr. Lekki has said, let's join the coalition. Let's join the USC forum. My group is in both. But let's be active at the subnational. Let's be active at the local government level. In the those are online, one of the questions that somebody asked before, or a contribution, he said, is it possible that all of us sitting here, we are told to give the names of our primary healthcare centers so that it could be adopted? I think somebody said something like that. Honestly, it should be very good, because the primary health center in my village is not adopted. It would be good, because if I know the ED centers are going to be a dashboard, but before the dashboard, let us know the primary health care centers that the census that was done had captured. So if we know any primary health care center that was not captured in the census, please, we put it in now. And because maybe we're closer to those, we'll be able to, working through this, the coalition and the forum, actively be able to work with those primary healthcare centers, because it's just got to be done. And I believe we're going to do it. Please, let's not allow this to go by us. It is a shame. In the village, if you have just malaria and it's above ordinary malaria, you die. Because you don't know how to transport yourself to the nearest place. And I know when we began, we're going to look at the cost of transportations. We have KK, we can turn it into ambulances. Let's please do tangible things. We must do tangible things. Thank you.
Thank you very much. I think you agree with me that you've had a very interesting conversation in this panel section. A number of things came out in terms of how do we do things differently? What is going to be the paradigm shift in terms of how NPHCDA we engage the other actors, the private sector, the donors, the partners, civil society, and everybody. I think the ED actually reiterated the new policy direction swap, which is simply about aligning around common priority, aligning the financial infrastructure or architecture, and aligning the monitoring and accountability as well, as much as possible to ensure that we are pursuing the same thing. Very interesting conversation on the local government autonomy. Of course, at this point, which is expected, there's still some divergent views in terms of how to pursue it. But something came out clearly: the need to be well informed about the decision that we are making. Somebody says to reform, we must be informed. Otherwise, we are going to deform. So in order to reform and not to deform, we have to be informed so that I generate the necessary evidence. And the issue of the need for us to be, all of us to be active advocates is very important, whether to join one advocacy group or the other, HSRC, USC, the health advocates. But the most important thing is to be very active from the grassroots to the national level, to be able to see the money that is going to our various community or what the government claim is going to our communities actually going there, and we are taking action and as much as possible. And again, the ED talk about the dashboard that they are going to launch. We look forward to it because the civil society will actually interact with it, because that's the source of transparency for what is happening. In a number of other Absolutely. So that when the dashboard come out, when they say in my community that I visited 2 days ago and they say everything is rosy and it is not, I'll be able to say, no, that is not the situation, and I'll be able to correct effectively. So I would like to thank the panelists for the great work, including those that have the ED that is no longer here. Thank you very much. Dr. Udom, we really appreciate your powerful contribution and the passion that you bring into the discourse. And Dr. Lekki, as usual, thanks for being there. You are on the 7th floor. We'll see you on the 10th floor as well, by God's grace. And those of us, we grow as well. And the rest of us, we grow. Thanks for being a veteran in terms of advocating for health sector reform. Dr. Babagana, all the way from Yobe, despite the stress and everything, we really appreciate your participation and your contribution and your great work. For your information, with evidence, Yobe State is the state where at the impact level, they have really improved at impact in terms of reducing mortality, reducing morbidity with evidence, survey evidence, not just one program report or something like that. So congratulations to Yobe State. Next time we'll be able to tell us the secret, despite the very challenging environment. And part of the secret is the other time I was reading that you actually sacked somebody